Hi, and thank you for attending the Who Are the Gatekeepers Symposium. My name is Dr. Tiffany Montgomery, and I am presenting today with Dr. Jasmine Travers and Dr. Shoshana Aronowitz. We are representing the Drexel University College of Nursing and Health Professions, the New York University School of Nursing, and the University of Pennsylvania School of Nursing. Our symposium is entitled Who Are the Gatekeepers? Evaluating Diversity Among Leaders in Nursing Education, Scholarship, and Practice. And we hope to just give you a little information about some interesting things we found having to do with diversity in who we consider gatekeepers amongst our profession. There we go. So by the middle of the century, the United States will have what we consider a majority minority population. And so what that means is that people that we consider minority, racial, or ethnicity populations or classes will be more than 50% of the population. Those people groups include Black or African Americans, Indigenous people, and other people of color, including Asians, American Indian, Alaska Natives, Native Hawaiian, Pacific Islanders, and of course, Hispanic or Latino or Latinx. Again, we will be more than 50% of the population by the middle of the century, but it looks like we may not be keeping up in terms of the nursing profession reflecting this change in racial and ethnic population in the country. So what we find right now is that the United States is primarily white, non-Hispanic. We have 1.3% American Indian, Alaska Natives, 5.9% Asian. Black or African American is the highest racial category with 13.4%, Native Hawaiian, Pacific Islander, 0.2%, Hispanic, Latino or Latinx, the one ethnicity that we usually account for with 18.5%. And I just want to put a little pin in that and remind us that Hispanic, Latino is an ethnicity that can be accounted for with every other racial group. So you can be Hispanic, Latino, and also Black, African American, or white, or also Asian, or multiracial. And so Hispanic, Latino in this accounting from the US Census isn't a category in addition to the other racial classes. It's separate. And so it's not counted in the total percentage. It's counted as a completely different category of ethnicity. And we'll talk about that a little bit later on as well. Multiracial, 2.8% of the population, and then white, non-Hispanic, 76.3%. When we look at registered nurses and nurse practitioners, in the statistics that come from the Bureau of Labor Statistics, we find that first, there is no accounting for American Indian, Alaska Native, and Native Hawaiian Pacific Islander because the numbers are so small. They also don't count for multiracial groups. So they're mostly looking at Asian, Black, African American, and then white, non-Hispanic, and as a separate group looking at Hispanic, Latino. Again, we see that as far as RNs are concerned, the highest racial group, minoritized racial group that is Black African American, followed by Asian, and then Hispanic Latino is about half of the US population. As we look at MPs, the minority groups get even smaller. You have Asian at 3.2%, Black African American 9.1%, and Hispanic Latino at 6.3%, just about a third of the population of Hispanic Latino in the country. And so as RNs grow to be nurse practitioners or gain more education and become nurse practitioners, the number of minoritized people in that group drops off. We also look at female population. So in the US, male and female are just about half and half. However, nursing being a predominantly female profession historically, we see that 87.4, almost 88% of RNs are women, and just about 88% of nurse practitioners are women as well. So why diversity? Diversity is extremely important for a number of different reasons. First of all, we really want our profession to reflect the diversity of the general population. The US population continues to grow in racial and ethnic diversity, and other professions continue to become more diverse as it relates to gender. And we're sort of behind in those areas. And so we want to catch up. We want to be able to reflect the people that we're caring for. Diversity also helps to mitigate health disparities. We know that there are some trust issues with some minoritized populations. We know that for good reason, they may want to see providers who look like them, who have experiences like they do, who share certain cultural norms that they share. And so diversifying the profession would help in that instance. It also helps when you have people of diverse racial and ethnic backgrounds and also diverse genders to be at the table to make decisions about how we care for people. And then lastly, the whole point of this is to improve health outcomes, right? We really want our patients, the clients that we serve, to have positive health outcomes and not negative health outcomes. And so that's the basic point of equity and diversity in our case. When we look at what we consider gatekeepers, we're thinking about a person or thing that controls access to something. And so in this instance, we're looking at 3 specific areas of gatekeeping. We're looking at nursing education, and those gatekeepers are who we know to be department administrators. So your deans, your vice deans, your assistant or associate deans, and other department administrators. We're looking at scholarship as a form of gatekeeping. And in that instance, we're looking particularly at scholarly journal editors. And then we're looking at service as a form of gatekeeping, and looking at organization board members in terms of the service that we provide, or the organizations that sort of guide the way that we practice, the way our nursing schools run, the way that we do nursing in this country. So the purpose of this symposium is really to investigate both gender and racial/ethnic diversity among nurse leaders in education. Again, those are our nursing school administrators, scholarship, our nursing journal editors, and practice, our professional organization board members. We all are using a lens of critical race theory, and it's not a specific theory in and of itself. It's really a group of thought processes, lenses through which you see the world. And so critical race theory says that, number one, race is a socially constructed concept. It's not something that's biological. There are no inherent differences between people of different racial or ethnic groups. But race is a socially constructed concept that we have come up with, and we've sort of created these tiers based on people's racial identity. Racism is structural and is systemic. So a lot of times we tend to look at racism as something that is based on the individual, and we see it as much more than that. Racism is interwoven into our laws, our policies, our practices, basically the way we go about life in this country. Critical race theory says that racism is interwoven into every facet of society. And so the idea that there are just a few bad apples here or there is rejected by critical race theory that says everything is affected by thoughts on race and racism. Critical race theory also says that structural racism helps to maintain power dynamics, where in this case, The white population tends to have the most power in this country, and that population benefits as the dominant culture, where minoritized people don't have as much privilege as the majority. Critical race theory also says that racism should be examined in dominant culture, and we shouldn't just look at biological differences. We shouldn't just look at things like environmental differences, but dig a little bit deeper and see what's under that. And a lot of times, especially in this country, it leads back to race. And then lastly, critical race theory tries to embrace the lived experiences of people of color, and says that they should not be shunned for being different than the dominant culture. We know that oftentimes in research, we've had a history of only looking at men in certain cases, only looking at white people in certain cases. And so we want to bring out the lived experiences of everybody, no matter what race, which gender. We want to include all people in our studies. The methods that we use are a little similar, somewhat different, but we all did observational studies where we analyze perceived race and gender, and that'll become important later on when we talk about limitations. And we looked at the most prominent nursing schools, journals, and nursing organizations to gather our data. And now I am going to turn it over to my colleague, Dr. Jasmine Travers, to begin with our first presentation. Thank you.
Thank you, Dr. Montgomery. I'm excited to share some of the work that myself, Dr. Montgomery, Dr. Aronowitz, and my research assistants who are acknowledged here on the slide, Rebecca Ding and Juan Gatica, have been working on in regards to understanding if the push that we are seeing for diversity in nursing schools has reached academic leadership. So just to give you a little background, although more nursing faculty of color pursue advanced degrees, disparities in representation of racial and ethnic minorities have been historically known to exist in academic nursing leadership. For example, full-time diverse faculty are more represented on the doctoral level than the non-doctoral level, as you can see on the top left. But on the bottom right, we see these groups less represented in senior faculty roles, which would increase the likelihood of one to be eligible to take on senior leadership roles. This racial and ethnic divide has implications for student and faculty recruitment, retention, and academic advancement. Particularly, nursing leadership dynamics driven by a lack of diversity in leadership positions prevents the success of Black and African American nurses and threaten their job security and health. Consequently, it has been noted that faculty of color have poor retention rates, which prohibits faculty in nursing schools from reflecting the populations that they serve. Moreover, lack of nursing leadership of color gives off the impression that the institution does not care about diversity, fails to adequately provide a picture of what role models in these positions look like, and makes it difficult to truly develop robust diversity goals that most commonly come from the highest level of leadership. Thus, changing the institutional climate and culture is necessary, and the role of administrative leadership is crucial to address current faculty of color recruitment, retention, and advancement concerns. We sought to assess the representation of faculty of color in leadership positions at the top 50 academic nursing institutions. Now, how did we do this? We conducted an environmental scan of academic leaders in a top 50 ranked academic nursing institution based on 2019 National Institute of Health funding information to assess the representation of racial ethnic minorities in academic leadership. We operationalized leadership as any individual, nurse, or professional from another discipline, who held a position as a dean, executive vice, associate, assistant dean, which also included a chairperson or chancellor or chief diversity officer position, or chair. For those who fit our leadership criteria identified through our environmental scan of the academic institution's website, we then extracted information related to their race and/or ethnicity, their gender, and title based on information provided in their bio and/or objective assessment made by the research team. And here to the right, you'll see an academic website. And pretty much what we will do is either go to the leadership page if the institution had one. If not, we went to their directory list and searched for these leadership positions to see who came up. And if we weren't able to search for the leadership positions, we just went through each faculty position and observed their titles to come up with those people who would be representative of the leadership that we were interested in. So race consisted of white, Black, Asian, ethnicity, Latino, and gender, female, male. So academic websites were the primary sites for data collection. We were unable to gather the information from academic websites such as the race, ethnicity, gender. For example, if a picture wasn't there, then we use other sources such as Google, LinkedIn, and other mechanisms of social media. So some institutional characteristics that we also gathered included region, so Northeast, South, Midwest, and West, whether or not the institution offered a PhD program, their NIH ranking, and whether or not they had a diversity leadership, a diversity committee, or had a website dedicated to diversity, equity, and inclusion efforts. Each faculty was given an ID number to conceal their identity, and then all of their information was removed when we were analyzing the data. So for our data analysis, we conducted descriptive statistics to characterize the demographics of our sample in general and by leadership type. We then performed bivariate analyses to examine the racial ethnic makeup of academic nursing leadership and the characteristics of the institutions where these academic leaders were employed. So our sample included a total of 409 academic leaders across the top 50 NIH ranked academic nursing institutions. And just starting from the top, you see the majority of our institutions, a little greater than 3/4 were public institutions. And then the location, majority of our institutions were located in the South, in urban settings. And then 7 out of 10 of our institutions had some type of diversity presence within their institution. And not shown here, but we did look at if a PhD program was offered. 49 out of 50 of these institutions did offer a PhD program. So here we have our racial ethnic makeup of the leadership positions. And just regarding diversity, you'll see that the executive vice associate assistant dean role was the most diverse with Black and Latino leaders, while chairs and deans were the least representative racial ethnic minority backgrounds. And in our data collection analyses, we considered racial ethnic minorities as Black and Latino. And then here you see the makeup of our Latino representation broken out from the other table. In regards to gender, of course, there's no significant difference. We already know the majority of our leadership also is representative of females when compared to males, but we see more males in the associate dean and the executive dean positions. So in those higher positions compared to the assistant dean and the chair. And here we see the actual minority makeup of the leadership by type of institution. So 2/3 of the deans along with the executive vice, associate assistant deans who were Black or Latino were in public institutions, while 100% of the chairs with these demographics were in public institutions. A larger proportion of assistant deans and chairs who are racial and ethnic minority backgrounds were located in the South in regards to region. And the lowest representation of racial and ethnic minority leadership was in the Midwest and West. There were no significant differences in racial and ethnic minority representation of academic leadership by NIH ranking. So that's what this table shows. But in general, we do see more representation in the top 10 institutions. So while our analysis yielded some interesting results, there are limitations to note. It is possible that there were discrepancies in data extraction. For example, we could have missed eligible faculty when conducting our scan. The 2 research assistants that conducted the environmental scan did do cross-checks, however. Second, in a few cases, it was difficult to classify gender and race ethnicity based on photo alone, and almost impossible to do so based on name when only a name was available. Third, data collection continued until October of 2020. However, it is possible that there could be changes in the representation of leadership given increased attention and diversity in academia in the recent months. Lastly, there are leadership positions that could have fell under the same category of the leadership positions that we included, but because of differences in the title, we may have excluded them. In conclusion, academic leadership, which minorities in our search made up 12.5% in the top 50 NIH ranked academic nursing institutions, is failing to match the profile of the population that it serves, which makes up 32% of the United States, as Dr. Montgomery showed us. So we're not meeting kind of this nice representation that we're trying to reflect. And then this problem was most pronounced in academic nursing institutions that were part of an Ivy League or private institution, or were located in the Midwest and West. It's important that targeted efforts are shifted towards these institutions, which may include lack of diversity of leadership, which the leaders need to agree with this statement and need to recognize the need for increased diversity in leadership. Then also assessing and highlighting structural and institutional racism, creating a safe haven for open discussions of racial and ethnic conversations, evaluating institutional climate and culture to improve faculty of color recruitment, and initiating changes within institutions based off of information gathered from assessments, discussions, and evaluations. Thank you for your time, and you can follow me on Twitter. Here is my handle. And I will hand it off to Dr. Aronowitz.
Hi, everyone. My name is Shoshana Aronowitz. I'm a family nurse practitioner and a postdoctoral fellow in the National Clinician Scholars Program at the University of Pennsylvania. And I'm so excited to be here with Dr. Montgomery and Dr. Travers. The title of my piece of this presentation is Diversity and Representation in Nursing Journal Editorial Leadership. So multiple studies have found that Black scholars are less likely than white scholars to receive NIH R01 funding. And this has been linked to both research topic preference and the number of publications listed in biosketches. So Black scholars are more likely to pursue community engaged research or health disparities research, which despite clear importance and value has unfortunately traditionally lower rates of being funded. And in addition, if journal priorities don't align with the work of Black scholars, their work might be less likely to be published, which could also impact their ability to get funded and advance their careers. So we're all familiar with the peer review process and the ways that this process should ensure that all the power to determine what is published doesn't lie in a journal editor's hands, but there's no denying that editors can set journal priorities. So with all this in mind, we sought to assess the racial, ethnic, and gender diversity of journal leadership in order to describe the demographic makeup of editors-in-chief and editorial boards of top nursing journals. So similar to the other presentation just described, Dr. Travers talked about, we identified the top 25 non-specialty nursing journals by impact factor during July and August of 2020. And we then identified the race and gender of each individual using their university, in most cases, profile. Race was identified by both picture and bio, and gender was identified using the pronoun in an individual's bio. And we use data to generate descriptive statistics. So as you can see, the sample included 185 individuals, including 26 editors-in-chief and 159 editorial board members. Almost 84% of this sample was white and 80% were women. And you can see the breakdown here. About 7.5% Asian, 3.8% Black, 1.1% Middle Eastern or North African, less than 1% Latino or Hispanic, and 3.2% the race and ethnicity was unknown. And then for gender, like I said, almost 80% female and almost 20% male. And then among the editors-in-chief, 24 out of 26 were white and 92% were women. So there is clearly very little racial and gender diversity among the top nursing journal leadership relative to the demographics of the nursing profession overall and the populations that nurses serve. And in light of these findings, journals should make concerted efforts to recruit nurses of color and gender nonconforming or non-binary nurses to join journal leadership teams. And one thought that we had was perhaps that journals could consider who is eligible to be on editorial boards and maybe consider inviting members from outside the traditional academic pool. So for example, nurses who work in leadership or clinical roles in community-based organizations. So there are some really important limitations to this work. So as discussed earlier, self-identified race really cannot always be accurately determined by a photograph. To do this work, we were inspired by the work of other researchers who have focused on workforce diversity. So an example is an important paper about racial concordance between clinician and patient by Greenwood et al. That was published in 2020, where they used similar methods. We did try to supplement information from photographs with bio. So for instance, if an individual was a member of an association like the National Association of Hispanic Nurses, but of course these methods are far from perfect. To somewhat mitigate this issue, we did use pronouns in bio to determine gender. And if there were no pronouns or no bio, then it was just the gender was marked as unknown. And ideally, this work would involve surveys where participants could fill out their self-identified race and gender so that we would not have to just rely on pictures and bios. So these are our references. And with that, I will pass it on to Dr. Montgomery. Thank you.
So I'm going to give our third and final presentation of this symposium, where I am looking at equity within National Nursing Organization board leadership. And I'd like to thank Dr. Damali Wilson, who worked with me on this, as well as research assistants Nazaf Shokat and Liam Giberson. So why do we even care about nursing organization leadership? Well, first, there are hundreds of professional organizations that are specific to nursing. Membership definitely helps those of us in academia and those of us in practice fulfill service obligations. A lot of these service obligations can help to increase rank if you're in practice, or help you increase a step if you have stepwise positions. Also, if you're in academia, service obligations are part of the tripart that we are all accustomed to. And really, if you want tenure and you want to serve your university, you need to serve the professional organizations as well, or serve your profession through organizations. Lastly, one of the big differences between professional organization service and the type of service that is rendered in an academic setting as an administrator or as a journal editor is that the vast majority of these positions are unpaid. So they're voluntary positions, which are elected by the membership, and there's a very short turnover. So you see people in executive leadership positions in nursing organizations stay in those positions anywhere from 2 to maybe 6 years if they have 2 3-year terms, but that's about it. And then they move on to another position or they go back into the general membership. The purpose of this particular study was to explore gender and racial ethnic diversity of professional nursing organization board members. And so we looked at the list of nursing organizations on nurse.com. We looked specifically at those that were under the national organization list. They also had regional or state organizations and then international, but we wanted to look at national organizations only. There were 178 organizations. We wanted to include only those that were for registered nurses. So there were some organizations that were for LPNs or LVNs, other organizations that were not specific to nursing, but maybe specific to a certain healthcare field. We wanted to look at those specific to nursing and that which you needed a registered nursing license to be a member of, or at least be a regular voting member. We excluded those organizations that had a specialty focus. So say one was focused on women's health, for instance, or critical care nursing. We wanted organizations that were general organizations that anybody in the nation who was a licensed registered nurse could join. We excluded those that were specifically for the military or people who, say for instance, were nurse educators. We wanted a more general guideline for membership. We also excluded organizations that were based on religious preferences or faith. We excluded those that had a non-functioning website where we couldn't see the board of directors, or those that had a website that hadn't been updated in 5 years, because we wanted more recent, accurate data. And so by the time we got through all of the inclusion and exclusion criteria, we were down to 18 organizations, and that left us with 178 board members. We looked at the different organizations, and there was really no difference between them. There were board members ranging from 2 to 15 board members per organization. There was a mean of about 10 board members on each nursing organization. They were from every region of the United States. The South had the most organizations and most board members, which makes sense because they have the largest population in our country, with the Northeast having the least. And there was one nursing organization that we could not find an address for. So we don't know where their primary location is. The sizes range from small, which we considered less than 100 members, moderate 100 to 1,000, and then large organizations more than 1,000 members. There were 8 organizations that the website did not display how many members they had in the organization. And we broke the foci down to 6 different areas, whether the organizations were based on advocacy work, education, meaning nursing schools or nursing education, general organizations for all nurses without any real focus, practice organizations, regulatory organizations, and organizations that promoted nursing scholarship. We found that the largest percentage of racial or ethnic population was with white nurses. 130 of these white board members were found. That's 73%. We found that there were 3% American Indian, Alaska Native. There were, I'm sorry, that's unknown. 1% American Indian, Alaska Native, 3% unknown, 4% Asian, 12% Black, and Latino or Latinx, Hispanic, 7%. As far as gender was concerned, we found that roughly 3/4 of the board members were women and about 1/4 men. So we found that representation of men on these boards was nearly twice as high as it is in the profession, which was really interesting. The racial ethnic makeup was not so different from what our profession is, but the gender makeup was very different. When we looked at minority status, so looking at white board members versus BIPOC, which is Black, Indigenous, and other people of color, we found that 7.1% of nursing board presidents were BIPOC or minority groups. 20% of vice presidents were minority groups. 25% of secretaries, 26.7% of treasurers, and then 28.4% of general board members. What was interesting about this is that as the level of, I'll say, executive board membership goes down from president being usually the top ranked person on the executive board through vice president, secretary, treasurer, and down to board member, who usually has kind of the lowest ranking on board membership, the amount of minority populations increased, which was just really interesting. If we broke it down even further, we could see that among presidents of these 18 organizations, none were American Indian, Alaska Native, or Asian, or Latino. There were 2 Black presidents and 25 white presidents, and then 1 was unknown. The same was true as far as white presidents outranking people of color, or I'm sorry, white nurses outranking people of color in the vice president category, secretary, treasurer, and board member. When we looked at gender, we saw that 28.6% of presidents were men, which again is, depending on what statistics you're looking at, 2.5 to almost 3 times as many men as there are represented in nursing alone. We saw that 10% of vice presidents were male, 18.8% of secretaries, 33.3%, so roughly 1/3 of all treasurers in this study were male, and then almost 24% of board members were male. Again, twice as high as the number of men in nursing alone. And so we saw that there was an underrepresentation of Black, Indigenous, and other people of color on nursing organization boards. There was a higher representation of BIPOC as general board members compared to executive board members, which again includes your president, vice president, secretary, treasurer, and a lower representation as board presidents compared to all other executive board roles. So they were less likely to be president than to be vice president, secretary, or treasurer. As far as men were concerned, there was a higher representation of men as executive board members as opposed to general board members. And it wasn't a huge difference, but it was a higher representation. There was also a higher representation of men as board treasurers, followed by board presidents, compared to other executive board member roles, either being vice president or secretary. And so we see that BIPOC are at the leadership table, but if you break it out by their actual roles and their elected positions, minoritized people or people of color are still not at the highest levels of board leadership. We seem to have made more gender gains than racial ethnic gains on nursing organization boards. And it would really be the due diligence of nominating committees to ensure that there is diversity on nursing boards. Again, unlike nursing administrators in schools of nursing or journal editors on scholarly journals and other publications, these are nominated positions, they're elected positions, and they're positions that turn over fairly quickly. And so we might be able to make gains in diversity on nursing organization boards much quicker than we can with academic institutions or with scholarly journal publications. And so that's something that we definitely need to look at. As with the other presenters, there definitely were limitations, including the ones that they stated. Perceived race and gender may not reflect self-reported race and gender categories. So we were able to categorize our data by looking at photographs and looking at names. There were 5 people who did not have photographs, but all of their names were visible. And so we tried to determine race by photographs and gender by photograph and or name where possible. Also, we didn't include every nursing organization that was on the list, certainly not every nursing organization that is registered in this country. And so there may be some nursing organizations that are doing much better with diversity than those that were included on this list. And now we're just gonna go into a summary of our symposium. And so you can see that among School of Nursing administrators, journal editors, and nursing organization boards of directors, there were twice as many administrators as there were journal editors and board members in nursing organizations. We see that among all areas, Asian nurses were underrepresented. They were mostly represented as journal editors. We see that Black nurses were greatly underrepresented as journal editors as compared to their representation as School of Nursing administrators and board of directors. But again, if you break those out, they were represented mostly on the lower end of administration and board of directors, not necessarily on the higher end as either deans or presidents, vice presidents. For our Latinx population, again, severely underrepresented as journal editors. In fact, there was only 1 found in the 25 journals that were included in these studies. White was overrepresented, particularly as School of Nursing administrators and journal editors. Not so much as board of directors, but again, if you were to break that out, you would see that white nurses were more likely to hold positions, higher positions on the executive board, and especially those of president. As far as other, it's pretty much the same across the board and as well as unknown. When we look at the gender breakdown, we see that men were overrepresented, particularly on boards of nursing or nursing organization boards of directors. So there were about twice as many men on these boards as represented in the profession in total. There's about 12 to 13% men in nursing, but 24% men on boards of directors. They were also overrepresented as journal editors and nursing administrators, not so much, just a little bit. Women were overrepresented in nursing administrator roles. And then, of course, we can't really speak to the unknowns. And so what? We as nurses have an obligation to the patients that we serve, to the communities that we serve, to our nursing students who will be our future nursing colleagues, and to others in the medical profession. We really want to be the driving force when it comes to diversity. We serve a very, very diverse population, and we see that the population in the US is becoming more diverse by the year. We want to be sure that by the time we have a majority minority population, we've caught up to that. Right now, we're definitely lagging. And so we want to do what we can to increase diversity, particularly where gatekeeping is involved, where you have people who are making decisions about who gets into nursing school, who gets tenure, whose articles are published, who gets funding, who gets to represent nursing organizations and make regulatory changes for the way that we practice and create guidelines for the way that we practice and advocate public policy. These are the things that are done at these gatekeeping levels, particularly nursing organizations. And so we want to make sure that we have diversity and we're representing all people in these positions. We don't just want diversity on the lower levels of nursing, we want diverse leadership. And that means leadership across the board. And so we hope that these studies can be expanded. We would love to go back and do more work with self-reported information, because again, we were looking at perceived gender, perceived race and ethnicity, but the work is important. And so we hope that it can continue. We would like to thank you for viewing our presentation, our symposium. And if you have any questions, concerns, thoughts, feel free to email us or contact us on Twitter. We're all on there. And yeah, thank you for joining us this evening.